So first, we just want to make sure you know, myself and Dr. Assadi do not have any relevant relationships or affiliations to disclose outside of employment of Savara Health, and no brand name commercial products or services will be discussed in this talk. So to start, the major points that come up from these acute stroke guidelines, and we'll of course go into more detail about these. This is the first updated guidelines since 2018 and 2019. The guidelines came out in 2018 with some updates in 2019. But a lot has happened. We've had a pandemic. We've had multiple other studies about treatment and thrombectomy, safety and timelines. And so now we have guidelines that have taken all these into account to give our best judgment going forward. These include the first clear guidelines on pediatric stroke management, and we'll talk briefly about those as well. These guidelines address recent research that compare IV alteplase or TPA and tenecteplase TNK, as well as whether and how to extend the time window for this IV thrombolytic treatment. Also addresses the safety of endovascular thrombectomy or EVT in specific cases, which we'll go into. There's been also research in whether to give certain other antithrombotic therapy, how aggressively to control glucose, how aggressively to control blood pressure. So there's some information on what is safe and what's not safe. Keep in mind that while we'll summarize everything for you as best we can, and with our expertise, it's important for you to also review the full document. It's available as a free PDF through ahajournals.org. You can search there, or you can even search on any search engine for 2026 stroke guidelines, and you're looking for the article with chief authors S. Prabhakaran and N. Gonzalez for your reference. First, I want to just address some of the important points of pediatric stroke management, so we're aware what guidelines are there. In cases of suspected acute ischemic stroke in a patient under 18, the guidelines currently still say that we prefer MRI and MRA brain and neck if available within 25 minutes of arrival, just as the reasoning being to try to minimize or avoid exposure to radiation, but that if it is known that it's not going to be available at the facility within 25 minutes, go straight for the CT head and the CTA of head and neck to identify things that can be eligible for acute intervention. It is determined so far from the research that IV TPA alteplase is safe as young as age 28 days old, of course, with dose adjusted for weight. The efficacy, however, is not certain. So it's safe, but it's not definitively determined to be efficacious as it is for the patients 18 and over. It has not yet been fully determined whether TNK, tenecteplase, is safe or uncertain. So still with pediatric patients, we're using alteplase, not TNK. We're understanding that efficacy may not match what's with adults, but it's relatively safe. There are also guidelines on thrombectomy, and it's found that if imaging is done, vascular imaging and large vessel occlusion, LVO, is found, endovascular thrombectomy is effective as young as age 6. For all patients as young as age 6 within 6 hours of last normal, potentially up to 24 hours from last known normal if you have a perfusion study that shows a large penumbra. In other words, there's a large amount of tissue at risk but not completed stroke. And it's actually relatively safe to even pursue a thrombectomy in a patient as young as 28 days, provided that we're in a facility with neurointerventionalists with pediatric experience, which we know are not very common. So it's important to keep those in mind, especially even if we're not directly in pediatrics. We just want to be aware that there are safety guidelines for TPA and thrombectomy in children, and that as you can see, the time window is a bit extended for children. So if you're in a position where you have to help direct or transfer a patient who falls in this age range, you should know that you shouldn't be ruling out a treatment or a plan to transfer a treatment just because of a strict time window for adults, which we'll go into as well. You want to try to get them even 6 or 24 hours from last known normal to where they need to be with the appropriate experienced professionals. There's the guidelines also addressed the usefulness of mobile stroke units, or MSUs, and it's determined that there's enough research that where they are available, MSUs are preferred over conventional ambulance to transfer acute stroke patients who are candidates for some form of neurointervention. That means within a good time window for intervention, and especially if it's in a community with the catchment area of a hospital system or ambulance system is quite far from the location of the hospital itself. We're talking beyond 30 minutes drive out. Keep in mind that mobile stroke units contain your standard things that you would have in an ambulance, such as ability to check vital signs, point of care lab ability, in particular glucose, INR, and creatinine. But they also tend to typically have a portable CT scanner, so we can quickly identify whether there's a bleed or not. Typically, they're equipped with a video, a card or video screen that has access to a teleneurologist, and they have IV medications that are not always available in all conventional ambulances, ability to give IV TPA or TNK with the neurologist's guidance and the information from the point of care labs and the CT scan. Also ability to give IV antihypertensive medications if we have to get blood pressure within safe parameters, as well as the ability to give vitamin K and or PCC if an acute bleed is identified. So again, these have been found to be useful, and again, mention especially in areas where the appropriate, even primary, if not comprehensive stroke center is far away from the catchment area, because that way a person can actually start getting acute first step of treatment, whether it's IV thrombolytics or something to reverse or minimize a bleed before they even get to the emergency room or hospital. So we may be seeing more of those being used in different communities throughout the country. And there's been research into considering the transport destination. Do we go to the closest ER? Do we allow the patient a little longer time so we can get to a comprehensive stroke center? The guidelines don't necessarily specify too many numbers with this, but it's a bit of a judgment call. But there's been enough research to show that if you know that you're in an area with a well-coordinated stroke system of care, so that means there's a good sense of where the primary stroke centers are, comprehensive stroke center, and there's good ability to transfer patients from one location to another if they need higher level of care, then there's really no advantage to going to a distant comprehensive stroke center, especially if it's 45 minutes or above of a drive beyond a local primary stroke center that can at least start initial treatment. If you know when you're in an area with poor stroke systems of care coordination, or just long distances anyway, even to a primary stroke center, then in those cases, you would consider transport to a distant comprehensive stroke center, and also consider implementing a mobile stroke unit system in that community to at least be able to start treatment earlier on before they even arrive there. But it's important for those of us who are here who are administrative in our role, it's important to establish ahead of time agreements and protocols to prioritize interhospital transfers for stroke patients who got their primary care in a local or a primary stroke center, but need to be transferred high level of care, such as a thrombectomy, such as access to neuro ICU. So that there's a certain amount of planning that's needed in place ahead of time to make sure that we can handle the emergencies efficiently in those cases. And I'll hand off to Dr. Assadi, who'll talk more about the considerations of TPA, TNK, and our extended time windows.
All right, thank you. So jumping in, TPA versus TNK, this is the first time, obviously, that this has been addressed by the guidelines. Basically, right around since when the last ones came out, this has been, TNK in general has started to become sort of rapidly adopted, initially in kind of larger academic centers, and now kind of small sites, large sites, far and wide throughout the country. TNK has, just to review for anybody who doesn't maybe have as much experience with it, but it has a couple of sort of inherent advantages. The first is that it's easy to administer. It's a simple IV bolus as opposed to the bolus and then subsequent 60-minute infusion of TPA. Because of this, there are some inherent sort of immediate potential goodness in that you can decrease door-to-needle, door-in, door-out times and so forth without really doing too much, potentially, besides just switching to TNK. And then it does cost less, although I believe it's been slowly but surely coming up in price since it's becoming more and more adopted. There are multiple phase 3 trials showing efficacy. We're talking about TNK, and I want to highlight the dosage there for any ED or pharmacy folks out there. There's a number of medications that TNK being one of them, or TPA, where you probably are used to using the same medication between the cardiologist and the neurologist. We generally speaking have lower dosages that we use, and I believe this is lower than what the cardiologist does use, similar to like Plavix and so forth. So that's the dose. A higher dose was not shown to have the same efficacy and safety. There's also demonstrated non-inferiority, and so the end result of all this, if it wasn't clear, is that essentially one is equal to the other. Having said that, the guidelines, while they're a little bit vague, offer an interesting paragraph where they state not that you should change, but if you're not already using TNK, given the sort of inherent advantages to it and the growing evidence-based, you might consider switching to TNK. So I thought that was kind of interesting and worth pointing out. Next slide, please. All right, so next up, I think this is, so I'm going to talk about the sort of extension of the time window for the administration of IV thrombolytics. This is probably one of the more sort of exciting, kind of more mass distributed, and probably one of the more sort of consternation or confusion inducing recommendations that came out of these guidelines. As anybody who's treated, more than one stroke patient in their lifetimes would be well aware, the last known normal, last known well can be a little bit tricky. Patient comes in with EMS, something is said, family comes in, something else is said, and it can be a little bit difficult. The guidelines, just getting to the meat of this, they basically break this down into two. There's the more established use of hyperacute MRI. That's coming off the wake-up trials and so forth. That's within 4.5 hours of symptom recognition or truly wake-up strokes. That is, I think, a more established use of emergent imaging to offer thrombolytics to patients who otherwise would have been excluded. It's obviously dependent on having an MRI for which you can get those initial images and look for the DWI flare mismatch emergently. So while not universally available, the folks and sites that have that, I think have probably had at least some success with it. As an editorialization, I can say that wherever I have worked where that has been available, we've definitely treated folks who otherwise wouldn't be treated with good results. Now to the new, more new, and again the meat of this, we're talking about IV thrombolytics being reasonable per the guidelines when you find a salvageable ischemic penumbra. So what we're really talking about here is CT perfusion imaging, which in the post Dawn and Diffuse 3 world, I think is becoming more and more available. The idea here is that you can potentially treat patients who are within 9 hours, who awake with symptoms, and you can treat them within 9 hours from the midpoint of sleep. So patient goes to bed at 10, they wake up at 6. Simplest thing is that midpoint is about 2 a.m. And if you can treat 9 hours from there, or about 4.5 to 9 hours from sort of the last known well as best that can be established. So that's the patient sort of found down and so forth, or take a nap or whatever the case may be. This is not quite as high of evidence, but it's still pretty high evidence to say that this is reasonable. But let's go to the next slide because there's some subtleties here. So a lot of this came out of the Extend trial, which essentially showed that what I've just said improved 90-day modified Rankin, but also came with increased risk of symptomatic intracranial hemorrhage. So it's a risk-benefit proposition. That's just the first thing I want to point out, as is TNK or TPA in general, but this is something to be aware of. And then in attempts at subsequent pooled and meta-analyses, this trend held. Improved modified Rankin if you can select the patients, but also an increased risk of symptomatic ICH. Along with those subtleties, I just want to point out that these folks had, generally speaking, had at least higher NIH scores or medium to higher NIH scores, so greater than or equal to 4 up to 26. The PDIs are basically talking about a core to perfusion mismatch greater than 1.2. That's less than what was the sort of 1.8 used in Diffuse 3, but basically what you're saying there is that there is a smaller core, a significant penumbra, so tissue at risk, and so there's something to salvage with your use of the thrombolytics. The notable exclusion criteria, kind of as always, is higher modified Rankins. That's basically 2 and above. So the patient has to be, generally speaking, functional. And again, it's pretty decent evidence. Now, that picture down there is just for anybody who may not be familiar. That's what Rapid or Viz or these similar programs kind of spit out after the perfusion imaging to show us what may be core, what may be penumbra. That sort of pinkish on the left there, that's sort of core, that's irreversibly damaged. That green is penumbra, that's not yet irreversibly damaged, but at risk if the patient were to complete the stroke, as we like to say. And there's a significant mismatch. Just to point out, that comes from Diffuse 3, which I also want to point out, as I think a number of folks' wheels may be turning in the brain as I'm saying all this. A lot of these folks have LVOs, and that's what the Diffuse 3 trial was about, right? And there is some data to suggest that, a successful thrombectomy without thrombolytics is just as good as thrombectomy plus thrombolytics. The idea being that there's old and newer data to suggest that once a clot reaches a certain size, TPA or TNK may not be able to dissolve at all. That really thrombectomy is the only way a successful thrombectomy is the only way that you're going to end up with really truly recanalization of the vessel. So if it sounds like I've just said something and then immediately said something against it, it's because, the guidelines are saying that this is reasonable, as I just said in the previous slide. But I just wanted to point out that I think when you kind of parse through some of the data I've shown, what I've just said, it's maybe not as simple as perfusion deficit, equals treat. Yes, no, easy binary. I think there's a fair amount of subtlety, and I think that's maybe why this trial, or this particular element of the guidelines has maybe been a little bit more, again, as I said, consternation inducing. So it's reasonable, but we probably need to continue to refine who is really going to benefit. There is some guidance from the guidelines themselves, but again, parsing through the data behind that, again, maybe not a binary decision. I'm sure there'll be questions on that, so I'll just move past that. But I wanted to point that out up front, that reasonable, but. All right, next slide. Moving on to non-disabling deficits. So yay for every stroke neurologist out there or anybody who treats stroke, this is now formally addressed. And it essentially says what I think has been common practice for all of us and sort of what we felt intuitively, which is there is no benefit to thrombolytics in low NIH non-disabling deficit strokes. Now that non-disabling is a little bit up for interpretation, but the guidelines use sort of the PRISMS trial as a basis. That was a trial that actually was unable to be finished due to a funding issue, but did prescribe at least in the table there on the right. I'm not sure if it's able to be seen, but that sort of is from the PRISM trial. Did prescribe a way of looking at and determining disabling versus non-disabling deficits. The idea being unilateral sensory loss, hemiataxia, but the patient can walk, an isolated mild aphasia that's improving. These have low NIH scores, and these are kind of the symptoms. There's really no reason to be treating with IV thrombolytics. It really seems that the risk-benefit ratio does not favor that. Having said that, same trial, same guidelines would state that if you have a true hemianopsia, severe aphasia, low NIH, but you can't walk, maybe that's a little bit more disabling, and maybe you really should be considering thrombolytics. And there's two sort of global points there that I want to make. First off, that the NIH is a guide, right? It's a number. It does have correlation under the best of circumstances with severity, but number does not equal treatment decision. We're talking about maybe a little bit more the art in addition to the science of medicine here. What is disabling? What isn't? What should be pursued? What shouldn't? And as a correlator to all that, there is a growing amount of evidence. Chance and Point are kind of the big ones. Aramis or Staley. There's a couple of other smaller studies and secondary analyses that basically say that when you have a low NIH stroke, that upfront loading with dual antiplatelet therapy gets you where you want to go. And the guidelines really are reflecting that as well in this. So non-disabling deficit, no benefit to IV thrombolytics. I think we can go to the next slide. All right, so now we're moving on to large core infarct. So just again, for anybody who may be less familiar with this language, so large core infarcts, we're talking about a large area of stroke. And when I say that, and I say core, I mean irreversibly damaged tissue. Aspects is a score that was used in the early trials and is still used as a way to look at what really is parts of the brain are showing ischemic change and ultimately core. When you look at trials, dating back 10, 15 years plus up to the more recent ones, what exactly is large core is less clear, but a more recent working definition is thankfully a little bit more straightforward, and that is essentially that if you have an aspect score less than or equal to 5 by CT head or MRI, usually it's going to be CT, within 6 hours of stroke onset, that's a large core, and reflecting, again, sort of the post-Down and diffuse 3 world, if you have ischemic core volume, again, we're talking about CT perfusion, of greater than 50 to 70 milliliters, that's reflecting differences between Down and diffuse 3. But within 6 to 24 hours of stroke onset, you would consider that probably large core as well. Next page. So this is essentially an algorithm for who would get thrombectomy. We're going to kind of hammer through that, but just to show that, so we'll go to the next slide. So to the large core infarcts themselves, just to try to be as clear as possible with them. So let's say you've established an LVO. So we're talking about internal carotids or the M1 segment of the MCA. There is, we've now kind of switched the way we speak about and research, sort of medium vessel, so kind of M2 and more distal vessel occlusion. So we're just talking about ICAs and M1s. So the next thing, you've established that, the next thing is time. Within 0 to 6 hours, you have an aspect score 3 to 10. So that includes, as I just said, essentially large core infarcts. Highest level of evidence, those patients should be going for thrombectomy. Additionally to that, 0 to 6 hours, but very, very low aspects, essentially as low as it goes, 0 to 2. The thrombectomy is reasonable. One kind of step below that in terms of evidence. There are subtleties to that, and they largely, we could talk about this in the questions if there are some, those largely reflect the inclusion and exclusion criteria that were set up for Down and diffuse 3, if you really kind of parse through that. So age less than 80 and NIH is greater than 10 and kind of some of these other things. But essentially it's reasonable. And then final one here, 6 to 24 hours, and the aspects is again sort of reflecting a large core infarct. I guess you'd say similarly with the perfusion. Thrombectomy is recommended. Again, there are subtleties. Again, they largely reflect sort of the Down and diffuse 3 inclusion-exclusion criteria, but they are reasonable. As a global editorialization, again, I would say for all these folks, I think the biggest change here that I would take from it is if you went back 5+ years, large core infarct, as the neurologist, as the initial sort of treating physician, you might say, hey, we're done here. It's a large core infarct. Now I would say, my takeaway from this is there are subtleties and maybe, neurointerventional should still be engaged. Whether or not they go, does involve their decision making and technical aspects. But everything here would tell me that, hey, these folks should be discussed. There's an LVO. Let's have a conversation about risks and benefits with the neurointerventionalist. We can go to the next slide. No, did it freeze? Next slide.
I think Neeraj is.
Are you able to see the next slide?
No.
Oh. Give me a moment. It's moving on my end. Are you able to see if a new slide has come up there?
It has not.
Give me a moment. Give me one moment, just restart.
Neeraj, did you freeze?
I think he might have froze.
Let's give him just 1 second here. See if he can. Otherwise, we will go to the backup slide.
Perils sometimes of technology.
All right, I'm going to share my screen so that you can continue, Dr. Assadi. Give me 1 minute.
All right, thank you.
I'm not as good as he is, so I will work on doing the full page, but once you go ahead and continue.
All right. So the next slide was just a sort of zooming in on what I just said. I'll let folks maybe then just look, if you're curious to sort of hammer that home, to look. Oh, there we go. To look at it on the guidelines themselves. It's just essentially taking you through essentially an algorithm for eligibility for endovascular thrombectomy. So LVO, time, aspect score, and then you break it down, modified Rankin, and where there is solid evidence and where there isn't. And a lot of what I didn't talk about here is essentially higher modified Rankins, and kind of some other inherent issues where the maybe the patient should or shouldn't get a thrombectomy, but the data just isn't there, and so no concrete guidelines were offered with this update. You still might talk to the neurointerventionalist, but again, it's a little bit less clear, the benefit, or at least not established. We can move to the next slide. And so I think last thing I have to talk about here is basilar artery occlusions. So this is a little bit more formally addressed, which I think is nice, because this is something I think everybody gets a little bit concerned about, because the outcomes can be so poor. Essentially, the basilar artery occlusions in the updated guidelines are split along exam findings. So if the patient has a modified Rankin of 0 to 1, a favorable aspect score, so let's say greater than 6, and the NIH is greater than 10, within 24 hours, thrombectomy is recommended. Highest level of evidence, talk to neurointerventional, and they should keep moving to the angio suite. We can go to the next slide. If, however, again, split along exam, that modified Rankin is the same, that aspects is the same, and the NIH is 6 to 9, so again, still reflecting possibly a significant stroke. And again, I would highlight for anybody who is less aware that the NIH is not, let's say, ideal in all cases for picking up posterior circulation symptoms. But here, the effectiveness and the functional outcomes of thrombectomy within 24 hours is less clear. Decent level of evidence. Would I still talk to neurointerventional? Again, just a few edit. I offer my own opinion here a little bit. Yes, but the guidelines basically say the effectiveness here is unclear. Again, those patients probably still go into the ICU and et cetera, et cetera. But that is what the guidelines say. Just a couple of things I want to note. We're talking basilar only here. There are no clear statements on the vertebrals, PCAs, kind of more proximal and distal. That is more subtleties are involved, technical considerations and so forth. And again, as with reflecting what I just said about anterior circulation LVOs, there is insufficient evidence for elevated modified Rankins, and in this case, particularly large core aspect scores, which there's again, for anybody who may not be as familiar, there is a sort of corollary aspect score for the posterior circulation, looking at the pons and midbrain and so on and so forth. And so last slide is the next one, which is just that portion of the algorithm in the new guidelines kind of blown up. And again, I encourage anybody to look through it and think about it. This will be, I hope, if Dr. Singh is back, it'll be back to him here. I believe he's trying to reconnect. Is there a way to add him?
I'm not. You should be able to come in just off the link. While we wait for Dr. Singh, maybe we could, I will unmute everybody if somebody has any questions, and then we can continue with Dr. Singh and comes back online. So if you just want to raise your hand, I will call on Sharif. Let me see if I can. Jen Harris, can you try unmuting yourself and
I have to say, if somebody's speaking, I'm afraid I'm not hearing you.
looks like Dr. Singh is coming back on.
Hello, thank you. Let me know if you can hear
You
and see
can
me
go ahead
now.
and take over.
Thanks, I'm sorry about that. No idea how that happened. Just get back there. All right. Dr. Sai, just let me know if when to stop if you're still going over some of those slides that here.
I've completed, so you can go to just past the vascular artery occlusion slides.
Got it. Okay, this as well. All right. I'll go over some of these points that I had taken. Thank you, everyone. Sorry for that inconvenience. So in the past few years, there have been studies looking into how aggressive should we be with controlling blood pressure, glucose, and whether to also introduce other antithrombotic therapies. So we have some guidelines here on what's safe and what's not safe. So in particular, if we start with blood pressure, after IV thrombolysis, so TPA or TNK, it's been found that there's no benefit to strictly controlling the systolic blood pressure to under 140 millimeters of mercury in the first 24 hours after the administration of the IV TPA or TNK. That's as compared with keeping it permissive up to 180. And after successful endovascular thrombectomy, there's no benefit to controlling systolic blood pressure under 140 within the first 72 hours, as compared with permissive hypertension up to 180. So again, no urgent need to drive down the pressure, but it also helps guide us that there's a bit of a different time window if someone just got their IVT or TNK versus if they underwent thrombectomy as well, that there's actually a longer period of time up to 72 hours where we want to keep hypertension permissive up to a 180 for systolic. There have been studies have also looked into whether to aggressively control glucose level, and it's been found that treatment with IV insulin to achieve a serum glucose level between 80 and 130 in the first 72 hours is actually counterproductive. It does not improve 3-month functional outcomes, and it actually increase the risk of hypoglycemic episodes. So while there's a long-term goal beyond 72 hours to get serum glucose levels to normal range, only slightly higher than normal, there's no urgency to drive it down in the first 72 hours. Additionally, as there have been multiple medications that are used for percutaneous coronary intervention when there's a myocardial infarction. So there have been some studies that have said, well, what if we apply that to endovascular treatment for the brain? So there have been studies looking at whether to give additional antithrombotics, such as argatroban or eptifibatide, with IV thrombolysis, which have been shown to be helpful in PCIs for the heart, even if there's a slight increase in bleeding risk there. It's been found it only introduces bleeding risk, and there's actually no benefit for outcomes if you're trying to do it in conjunction with IV TP or TNK. And specifically, tirofiban is used often before or in conjunction with PCIs during those procedures for the heart. But administering this before endovascular thrombectomy also has been found to show no benefit, and it only introduce a little bit increased risk of bleed. Therefore, we stick with just your standard IV TP or TNK, and then thrombectomy, no additional supplemental medications found to help. There's also been research looking into IV glibenclamide, or in the US, glyburide, to reduce cerebral edema in the setting of large infarcts. However, it's been found there's so far no benefit. There's been some promise on preclinical trials, but in any human trials so far, it has been found to not be beneficial. So no role to add this medication to help reduce edema. Good. And so summary findings, not sure if this was just covered, but just to recap a little bit, that in general, the guidelines are leading us to change our focus in stroke treatment from a strict time since last known normal to evaluating tissue at risk. And that's the base upon which there are suggestions to increase the time window for management, that if we do have enough information showing there's a lot of tissue at risk but not complete infarct, we may be able to still administer some of these medications. And that we can help more people than just ruling people automatically out just because of the last reported time being farther out than ideal. There's been increased focus on improving the logistics for stroke care, having those mobile stroke units, having those inter-hospital transfer agreements in place for expedited transfer. In other words, having things in place ahead of time so that we're not having delays during the stroke care emergent period, clearer guidelines on pediatric stroke management, and clearer guidelines and recommendations on managing other systems, in particular blood pressure, glucose, and essentially no role for other antithrombotics besides what's already proven. Ultimately, each hospital system has been informed to decide essentially if and when to adopt these guidelines. And key things are that a hospital or a hospital system really needs to have easily accessible perfusion studies, such as CT perfusion or rapid MRI capability, as well as likely easy access either in their own hospital or easy transfer to a neurointensive care unit in order to adopt these guidelines safely. We are reminded that a lot of these studies are based on care and protocols done in comprehensive stroke centers where access to these are readily available, but applying them to every place, all the communities, may be more challenging. And so we must take into account what our current limitations are, what our ability to incorporate some of these advanced systems are in place before we can safely adopt those guidelines here. Thanks. We'll head to the questions. So Dr. Sai, I understand you started
real
answering
quick,
some
Dr.
of these.
Singh, I wanted to interrupt you just real fast. I did turn on the chat there. We tried to do questions while you were out.
Gotcha.
So for the attendees who do have a question, please go ahead and put it in the chat. We will answer those as they come in and as time allots for them here at the end. Okay.
Thanks. For the if we start with some of the pre-submitted questions, as we see if something's come in the chat, many of the questions centered around the implementation of the guidelines for extended time window. In particular, how are different centers already implementing this extended window, if at all? How does it impact primary stroke centers, which may have no ability for perfusion studies and even limited MRI capability? And in fact, what about all the research going on that might even be talking about extending the window even as far as 24 hours? Do we have any response to that? Dr. Sai, again, I don't know if you had started answering a question like that, but want to check if you wanted to start addressing some of these.
Sure. No, I haven't started to address them yet. So, so for the first question, it's honestly, so, well, first off, this recommendation is hot off the presses, right? So even within our own company, even within our own sites that we treat patients, this is something that is sort of actively being discussed. I don't have an answer as far as one clear implementation strategy. It really depends on how big the site is, what they have available. Reflecting what I said before, so it's not so simple, I think, as just, oh, you have perfusion, you can do this, and then, if this, treat, if not. There's a number of subtleties that are sort of inherent to it. And I would also just sort of add there that, ultimately the evidence for all this comes from sort of large academic centers and the StrokeNet sites and so on and so forth. So I cannot give you, I'm afraid, a single way that this is being implemented. In a more generalized sense, I can say that where the discussions have begun, it is, it's multi-team, multidisciplinary, looking at the logistics available, what is sort of available at the site, and what makes sense or doesn't, and what is realistic or not. There is still, if you can't do perfusion, if it's just not available, if it's not there, you have what you have. Let's say the CT and CTA, you make your decisions and you keep moving. And kind of reflecting also something I said before, if there is a true LVO and you just can't find a way to give TNK, well, you got to keep moving that patient along to the angio suite, rather than kind of slowing things down, trying to find some way that may not end up working to give TNK. For the, what was the second? So how does this impact with no perfusion studies and limited MRI? You go with what you have. If there is, clinical concern for an LVO, and you just don't have that available, or CAT scan is down even at a site where you do have it available, or the angio portion isn't going to work or something like that, and you can reasonably transfer the patient, then we would, generally speaking, transfer the patient and try to get it done if we think there's a potential benefit. But otherwise, you have what you have, and you make the best decisions that you can based on the available information. Right, so up to 24 hours. So that is, so for anybody maybe not able to read or see it, so the most recent IC presentations and research, like the Wake Up trial, suggests that IV thrombolysis window may be extended up to 24 hours. That is more controversial. So yes, there are studies of various types, overall size of those studies, quality of those studies, suggesting and trying to find a way to continue to extend this window up to 24 hours. That is not standard practice. It is not reflected in the guidelines. So that may be coming down the road, but it's not here yet. Maybe next slide.
Thank you. Yeah.
Or next question.
I just want to briefly add that keep in mind, yes, if you don't have perfusion study capability or the wake up MRI capability, that just already tells you can't really adopt the extended guidelines in the current state because it's dependent on being able to see that information. So that kind of makes your decision easier for now. It's just a question of whether it leads you to have discussions of whether to adopt or include some of these in long-term plans for what you want to have at your centers. But I will tell you, in discussion in the New York City area with a few academic medical centers, even them are cautious and not yet adopting the extended window guidelines out of abundance of caution, waiting for some more information. There are indeed some trials out there, research that has suggested 24-hour window, but those have not been consistent. At least one or two saying it's safe, another one or two saying it's not clearly safe. So more research into whether we could even extend the window longer. And I'll go to the next one. Okay, give me just a moment. I apologize. I'm not sure why this is a bit slow on my end to proceed, but I can bring up one of the questions that came up was what should especially people going through a neurology clerkship, like medical students going through a neurology clerkship, learn from this takeaway points from these updated guidelines. Dr. Said, do you have a suggestion of that first before I continue?
Sorry, repeat that. I will admit I was looking at the chat for questions.
Oh,
while
sure.
We were waiting for the slide.
Just any takeaway points that medical students going through the rotation, neurology clerkship rotation, should learn or take away from these updated guidelines.
I think the biggest one, as my sort of immediate off-the-cuff answer here, is that the acute stroke care is I'm a stroke neurologist. I think is very exciting and is growing, and I think we're successfully treating more and more people. I think if you're going through those rotations, the things to kind of try to pay attention to and learn once you've kind of hammered home TNK and inclusion exclusion criteria and all that is sort of this use of more advanced imaging and how that's really shaping what we want to do. What does there's a whole, we could spend an hour on discussing what really is behind core and penumbra and cerebral blood flow and volume and mean transit time and all these things that go into it and what that means. And if you really are truly interested, I think it behooves you to kind of try to understand what is behind this, because the end result, so that picture that I showed you with core and penumbra, I mean, we try to simplify it as much as possible because there's a lot going on, but there is quite a bit that goes into it. So I think the more you understand the underlying basis to things, the more you'll kind of understand what we're doing on the back end. At the same time, I would say, for students in particular, learn your exam, learn the stroke syndromes, learn to try to understand what it is you're seeing. Ask a lot of questions, especially of your let's say the senior residents, your attendings when you're going through your rotations. That's my off the cuff answer.
We have a lot of questions in the chat about the slides, and we will get those out to everybody, and we'll include the few questions that we might not get to. The questions, Dr. Singh, that you were moving on to, do the 2026 guidelines do they address the role of speech pathologists or the use of GLP-1 drugs? And do we still keep the, I am going to butcher this, HOB less than 30 degrees for patients awaiting thrombolectomy, and then criteria to defer MRI brain to the outpatient setting?
I can start addressing some of that. Just regard the recommendations about the head of bed being flat or at least under 30 degrees hasn't changed or been adjusted. That's still something that's recommended, even in the setting of these guidelines. The criteria to defer MRI brain to the outpatient setting, possibly for a minor stroke or TIA, it doesn't explicitly address that. It's just that it shows that even in non-disabling strokes, as Dr. Assadi mentioned, even if IVT, PRT, and K is not indicated, we should still be administering dual antiplatelet therapy. And that's also a guideline that pre-exists where TIA, transient ischemic attacks, that wasn't explicitly addressed in the acute stroke guidelines here. So I would say that deferring MRI brain to the outpatient setting because of limited resource in the hospital may be appropriate if we're dealing with a suspected transient ischemic attack or minor ischemic stroke, meaning with a stroke with non-disabling symptoms, as long as the person is being discharged with dual antiplatelet therapy, at least for 21 days, if not longer, based on their how significant any vascular disease is, and with a stroke follow-up in place, so that there actually can be an assessment of how long those antiplatelets need to be there. There can be the actual order for MRI brain, that a person is not waiting, waiting for further guidance and waiting without an MRI. That's how I address those two. Dr. Sai, do you recall? I don't think there was explicit mention of any role of GLP-1 drugs in the guidelines. Let me know if you recall anything specific. I just think it wasn't addressed.
I don't believe so. I think I would have to review. I don't remember specific guidelines around it. I think, as with a lot of things, though, the ultimate effects of this is we are maybe more endpoint focused, as opposed to how you get. So it's important that you get there, blood pressure, LDL, et cetera, maybe more so than how you get there in many cases.
Great. And I'll just briefly add, there was a question about the role of a speech pathologist. Again, no change in the guideline of having the standard dysphagia screen. That's just the best SWOT evaluation in advance at the beginning. There was a mention of recent research that there's a role for where appropriate, where a patient is safe to receive it, that if dysphagia is a major component of a person's ischemic stroke, that there's a role for adopting neurostimulation in the recovery treatment process. And so whether that can be started in the inpatient setting or really part of the outpatient speech therapy plan, that there have been good outcomes for improving dysphagia secondary stroke with use of neurostimulation during the recovery period. That's the major mention of any speech pathology component in these guidelines from what I've seen.
Okay, I think we can grab a couple from the chat. I guess it just kind of depends on how
Sure.
the questions are. Would you still consider IVT and wait for reperfusion versus going to EVT?
So sorry, say that one again. So
would you
wait.
consider IVT and wait for reperfusion versus going to EVT?
I want to make sure I'm interpreting IVT. So we're talking about IV thrombolytics. You're talking about, okay. Just make sure I answer the question appropriately. So so if you don't have perfusion imaging and you think you have the ability to treat with thrombolytics, you should treat and then keep them moving. By the same token, if you find it, so if you, let's say, sites where you bundle a CT and CTA and you find yourself an LVO and the last no normal, let's say it was a wake up and you find yourself an LVO, you should keep that person moving to the angio suite instead of trying to go back and do, let's say you have hyperacute, instead of trying to go back and do a hyperacute to find a way to give TNK. Essentially, all you're doing there is potentially introducing a delay. So if you have an LVO that's potentially treatable, just keep the patient moving to the next phase. And again, I think I did mention somewhere along the way, there are a number of papers that would suggest that successful thrombectomy is essentially just as good as for an LVO, is essentially just as long-term outcome is just as good for the patient as TPA or thrombolytics and the thrombectomy. That's not across the board every case ever, but my takeaway from that is, again, if you find that LVO, just keep the patient moving. If you don't have a reasonable way to treat with TNK or TPA in the emergent setting, right then and there.
Yeah, I would agree. Thanks. Amanda, I'll just mention just some questions that came up in the chat. I think I can address a couple of them. Lots of questions about how to modify or adjust the EMR, electronic medical record system, health system to accommodate some of these. So indeed, someone has asked how important it is to get the last note, like the bedtime, the wake up time. That is now going to be more important to have a clear idea of when someone has gone to sleep, when someone's woken up. It would be if you have an EMR that is adjustable, that already does calculations based on information entered, but you're able to modify that. Yes, it would be good to implement essentially an automatic calculation of what the midpoint time would be of sleep based on that information, because in an emergent setting, it can be a quick thing to miss or to miscalculate without having that check. And someone has also mentioned, given that alteplase right now is what's considered safe and not TNK for pediatric patients, indeed, there may be a role to introduce or incorporate like a checkbox to indicate alteplase only for a pediatric patient if you're considering someone under 18 in your system versus avoiding the risk at this point of giving TNK under the age of 18. And again, with this and with other things, good to have these things in place, but also something that can be modified because it's all based on what research is there. It's just that TNK, tenecteplase, hasn't been proven to help with pediatric cases. Maybe down the line there will be, and there'll be a role to modify it further to say that that's acceptable. But at this point, just with limited evidence, it would be useful to have that kind of, or adopt that kind of marker checkbox in your EMR to make sure the not proven safe medication isn't given to the wrong patient.
I might jump in there and strongly agree. I think as much as some of this can be sort of automated, especially if it's put into the EMR as possible, it's going to be useful for any of us sort of running the stroke code. I think one of the themes of what I had to present was that there is the introduction of a lot of subtlety, and I think it's only going to get more and more subtle as the evidence, which particular patient should be getting this versus that, going here versus there. And so, when you're seeing a patient, trying to examine a patient, trying to recognize a stroke syndrome, disabling deficits, make your decision, review the imaging, all this in like 10 minutes, right? And you have all of this extra stuff coming at you. I think to reference what Dr. Singh said, the risk for a mistake on our part at some point is going to go up, right? Because you're just being bombarded with information while you yourself are trying to get information. Maybe a little bit different in academic centers where if you're the attending, you know, the resident, the fellow is actually doing the exam and all that. But the point is that there's a lot of, it's only getting more complicated. And so anything that I think streamlines that is potentially very, very useful. Obviously, you want to make sure you have the right information going into the EMR as best as possible, but I would strongly agree with that.
Awesome.
And then,
Well, Dr. Assadi, Dr. Singh, thank you on behalf of everybody who was able to join us today for sharing your time and your expertise and your genuine dedication to getting this right. This was a wonderful presentation. I know I'm a little biased because I'm Savaro, but I do think it was a great, great presentation that was well received. And thank you to everybody who joined us today for coming and spending an hour. I hope it was able to be worth your time. Any questions that are left over in the chat, we will send to Dr. Assadi and Dr. Singh for answering, and then we will go ahead and share the presentation in PDF form with everybody who was able to join us today. Thank you.
Just a quick reminder, when you share the slides, the last slide does include our content if you want to email us directly, but I just put in the chat as well, neeraj@savaro.com, that's NERAJ@savaro.com, or Rami, RAMI@savaro.com. You can reach us with your questions if you didn't have them addressed here. Thank you.
Thank you very much.
Thanks, Amanda, again.
yeah, thank you.